Hello and welcome you all back to the CRISP TV. Today is 11th October 2025. This is the second day at the conference, CRISP conference, and I am your host. My name is Dr. Abad Khan, and today with me is Dr. Ajit Menon. He's a renowned consultant cardiologist working at HN Reliance Hospital, Mumbai, and actually does not need any introduction whatsoever. So welcome again.
Thank you, Abad.
We have been seeing this the rise of the technology, the revolutionizing the coronary field, especially in the field of calcium modification, with cutting balloons. The rotablation is already there. The IVL, the new generation of IVLs are coming. Do you feel that even after the trial Eclipse trial which was published, do we still have an interest in orbital atherectomy? Should we still pursue, or one trial does not make a difference?
I think when we talk about calcium modification, the reason we look at calcium modification is because without modifying the calcium, your stents will not expand, right? Your balloons may not cross, your stents may not expand completely. You'll end up having a under-expanded stent or a malapose stent, and that's going to lead to complications. Now, in terms of the different types of atherectomy devices that we have, of course, orbital atherectomy is one of the newer kids in the block. But I believe that each of these devices have their own place in the management of patients. Now, in the Eclipse trial, it also showed that laser was not as good compared to the other devices. You look at the problem is with laser is not supposed to be used alone as a single device. Because it's only to create a path or for creating a way in lesions that are difficult to cross. Whereas with use of orbital atherectomy and with rotational atherectomy, I think both of them have their own niche places in the management. Rotational atherectomy has been there for donkey's years. Orbital atherectomy for us is a new device. But I think the issue with orbital is that you have to be very slow and patient when you're using an orbital atherectomy. Unlike the rotational, where you can do things a little fast, in orbital you need that time, you need the patience, you need to know which patients to select, you need to know which patients are going to do well with this form of atherectomy. And I think I don't see that there is anything there are any negatives about the orbital in terms of the trial. I think one trial probably, like you said, is not enough to draw conclusions. Used in the correct perspective, each of these have their own places and their own ways.
Perfectly. One trial may not be enough, and the data and the usage and the anecdotal data and the registry data and the personally used data has been quite growing actually for orbital atherectomy for some of the calcium modification, especially in fields of nodules and diffuse diseases. So coming back to a very commonly faced situation by the new generation of interventional cardiologists also, that what changes in a STEMI? How important is the need for hemodynamic support? And as a person who is practicing in India, an interventional cardiologist treats STEMI, how and which hemodynamic devices to use, and actually what to be used to for better outcomes. What things have to be done in a STEMI?
I think in a STEMI, in an acute myocardial infarction, your goal of therapy is to reperfuse the myocardium, right? So the point is you need to open the vessel. You need to get a TB3 flow down the artery. You also need to ensure that you have a tissue perfusion grade, which is also grade 3, right? If you do not have a tissue myocardial perfusion grade, which is grade 3, you just have an open vessel, which is maybe TB2 or TB3, but there's no perfusion to the myocardium. The smaller vessels are clogged. You lose the entire benefit of the procedure. So the most important thing when you manage a STEMI is how do you manage the perceptive thrombus load in these patients. You need to be aware that there's going to be some thrombus load. You need to be aware how do you manage these patients, and what techniques do you do to open the vessel, and how do you reduce the distal embolization and slow flow and no reflow phenomena. Now, when you also look at STEMI, we also need to understand that a lot of these patients are hypotensive. When these patients are hypotensive, if you try and do a procedure when the blood pressure is on the lower side, because coronary flow is diastolic, and with the low diastolic flow, with a low diastolic pressure, the coronary flow is still going to get a little more stagnant. It's always better to maintain the pressure slightly high in these patients when you try to attempt to do a angioplasty in a STEMI. I don't mean that you maintain a pressure of 140, 150, but you can at least maintain a pressure of 110, 120 if you can. And for that, basic intravenous supports are good enough. In some cases where the patient comes in cardiogenic shock or the blood pressure is too low, the easiest way thing that we have today with us is of course the IBP. Most of the trials have shown that IBP does not benefit. I think we still have a place for intra-aortic balloon pumps, and I think that should be the go-to hemodynamic support in acute STEMI. There are trials with the Impella device, but two things. One is availability. Second is the experience with the number of people who have experienced the Impella, and the support staff who has an experience with the Impella. And third, of course, is the cost of the Impella. All these are going to be deterrents in terms of using an Impella, though statistically and in terms of logistically speaking, an Impella would be the best device because it at least creates a flow of 2.5 or 3.5 liters. So that's definitely the best subset if you can do it with with an Impella device. But I think in our system, in our country, at this point of time, the best support that we have, other than the intravenous supports that we can give a patient, is of course an IVP. And what I would also tell most of the youngsters is that you need to, when you have an acute infarct, when you have an acute vessel closure, you need to treat the artery with respect. If you are very brash and very rough with the vessel, you cause a distal embolization. You get the thrombus going distally and clogging the microvessels. Even if you have an open vessel after that, it doesn't make sense. You have the damage has already been caused. So that is one thing, is opening the vessel, getting a TIMI3 flow. Another thing is maintaining a good tissue perfusion flush in these vessels.
Absolutely, sir. This is what the seniors can tell the people who are just starting on the interventional journey, that maybe the best way out may not be the only angiographic pictures, but actually the hemodynamics of the patient that tell you the real picture of these patients, and not to forget that balloon pump still remains our best bet in hemodynamic support devices, which is actually available to a large extent than Impellas. Should the sir seasoned imaging gurus who does only an OCT and IVUS for all stable patients also, and as the old saying has been, just go quickly, stent and come out quickly. Should this remain the norm in STEMI?
Uh, I think imaging will help to reduce the amount of device usage in some patients, because if you have just a plaque erosion, you don't stent. If you have a plaque rupture, of course you stent. But I don't. I mean, in our setup, I don't think we need imaging in all STEMIs. It's not mandatory. If you get a good result, I mean, if you have a straightforward lesion, of course you can go ahead directly treat it, stent it, get the vessel open, minimize the contrast load, minimize the support, the downtime to the patient, and get the patient off the table. Now, in certain situations where you have a question mark, is that you may have a doubtful scenario, whether it's calcium, is it a thrombus. There, imaging will help you differentiate between a calcium nodule versus a thrombus in acute situations, because then the treatment modality might change depending upon what you find in these situations. Otherwise, I don't think that it's right to advise that you do imaging in all STEMI patients, unless of course you are interested in knowing what the anatomy is, and you're interested in doing some research on these patients in terms of what is the primary disease pattern and what are the outcomes in these patients.
Absolutely. Maybe this is not the best way out, or maybe this is the best way out. Only time will tell. We should have more data for this in a STEMI patients, but Dr. Ajit Menon says that if it is a straightforward lesion, the usual dictum still remains very strong. Uh, how, sir, IVUS and NIRS, the dual imaging modality which is coming up, is it going to change any practice, or it will be only a use case scenario where you can use it in some of the vessels, maybe
I think the
for liver
IVUS
plaques and
NIRS
so?
has a niche place in imaging because it uses technology to detect lipid plaques, lipid-rich plaques, and there are studies that show that if you have the lipid burden which is beyond 400 at a specific vessel in a specific place, these are more likely to cause dysembolizations or no reflow phenomena. That helps a lot in terms of imaging, in terms of finding out, deciding what is your treatment patterns. It's the only modality which can detect a lipid behind a calcific plaque. So yes, though I mean, it does not have a great this thing over routine IVUS imaging or routine OCT imaging. It has a niche place in the detection of certain situations where you need to understand the plaque burden and you can plan your treatment accordingly in these patients. So that there are certain situations with high plaque burden, with high lipid burden, you don't use high pressure balloons, you don't use debulking devices. So these are certain subsets of patients where it will definitely be advantageous.
So a case scenario is what sir is recommending, and that is how it should be. Each devices for each scenario. That is what the imaging has taught us till now. Sir, you are a course director for CRISP conference, and we have all witnessed this amazing growth and popularity with the incredible space to learn cardiology. How proud and satisfied do you feel, sir, for this?
I think I definitely feel proud, but there's a long way to go to feel satisfied because I think we still have a lot more to do. We basically started this with an idea that we need to teach what we know to the youngsters, to the people who are going to come into practice and be the leaders of tomorrow. So I think it's still a goalpost which is still a long way off. But I think with the popularity growing and with the way that we have worked around the agenda for this meeting, both Ankur and Dr. Rahul, they've done a wonderful job in terms of curating the entire meeting agenda. I think it definitely makes us proud to be a part of this meeting. And I'm sure this meeting is going to grow in popularity. And I wish that more and more people come to this meeting because our basic agenda is just purely academic, purely to teach people what the seniors know and and we also get to learn from youngsters because medicine is a ever-changing field. So it's not a one-way direction of knowledge. It works both ways.
Perfect. These are the last slides that is speaking wisdom, and this is Dr. Ajit Menon. Thank you so much for the crisp TV, and see you on the next podcast. Thank you.
Thank you so much.
Thank you, sir.
Thank you.